So, let us examine this lady who kindly consented to go through this video demonstration on how to do an abdominal examination. She is priming gravida at 37 weeks of gestation with diabetes, and she is presenting today with mild abdominal pain. The same principle applied for her examination as well. First, we have taken already the consent, and now we have exposed her abdominal obstetric abdominal examination up to the sternum to the pubic symphysis, and her hands are either side of the tummy. And on inspection, as we discussed in the previous demonstration, there is linea nigra and striae gravidarum, and if you look at her tummy, it is enlarged, and we look for the surgical scars where it is usually covered, and there are no surgical scars in the lower tummy. She has no scars in the umbilicus and elsewhere as well. And I can see very little fetal movements if you look it carefully. The next step is to go for the palpation. Here, as we said, we are looking for the symphysiofundal height, and we take the symphysiofundal height as a proxy measurement for the fetal size, and she is a diabetic at 37 weeks with a enlarged abdomen. So, we need to do it properly. So, we start with the sternum, where that is the highest point where the symphysiofundal fundus of the uterus can go up to, and we use a border of your hand, either radial border, palmar border, or the fingertips, like that, like this, or even like this, whatever you prefer. I prefer my radial border, so I use my radial border to examine her symphysiofundal height. So, I start from the sternum, I will go gently down towards the pelvis, and it is very gentle movement of my hand where I first feel the resistance, and that is the where I first felt the symphysiofundal height there, the fundus. That is the highest border of the fundus. As I mentioned before, if I press further or harder, I am going to miss that fundus, and if I press little down, I still feel another resistance, and that would be the fetus. So, that is not the right way to check the symphysiofundal height. So, you need to be gentle, you need to come down slowly, at least 1 centimeter by 1 centimeter, and you feel the fundus when you feel the first resistance. And once you feel the fundus in the midline, you need to move your hand to either side to find out the contour of the uterus and to find out the highest point of the fundus. It can be in the midline or it can be shifted to one side. Here in this lady also, the fundus, maximum point of the fundus is in the midline. So, then we are going to measure the symphysiofundal height. How do we do that? So, we take a tape, we turn the centimeter side downwards to avoid bias, and I keep my tape at the fundus, and then I slowly come down using my thumb, feeling for the upper border of the pubic symphysis, and that is a pubic symphysis. And if we turn it, it is 45 centimeters, and she is 38 weeks pregnant, and this is more than the period of gestation. Now, let us move on to the assessment of the fetus. Now, we first like to examine the lower pole. So, we go for the lower pole, and we are looking for a big structure like that, either head or the breech. So, we use our palms instead of using any borders or fingertips. That is one principle. And we are going towards the pelvis because the uterus is coming from the pelvis, and the presenting part of the fetus is supposed to go into the pelvis, not onto the surface. So we start with our palms symmetrically placed either side of the anterior superior iliac spine. While you are looking at the face, we go down deep into the pelvis and parallelly we move our hand, and at this point I can feel a hard round mass, and this round mass is um, in the abdomen, not even gone into the pelvis, so that I can take my hand below the mass like that. So it is a non-engaged head in the lower pole. In that mass I can ballot the mass because it has not gone into the pelvis, and I felt the little constriction, and then it expands to the abdomen, showing that there is the head and it continues with the shoulders. Now to confirm my findings, I also want to check what is in the upper pole. So I turn myself like that, use my hand parallel to her tummy, the same way I feel for the upper pole, and I feel the firm mass which is continuous with the trunk. So I feel the back while I am feeling the upper pole. Here also I am doing the same. Now in this lady, I feel the baby's back on her right side, where I feel the lumps on the left side. So therefore, this baby is in cephalic presentation, longitudinal lie, and right occipital anterior position. And at the same time I can say, because this is head is not engaged. It's totally in the not into the pelvis. So it's 5/5 palpable in terms of palpable fifths. While I was examining the fetus, I also get an idea of the lycopodium. So you don't need to separately examine for the lycopodium. And now I am going to listen to the fetal heart. Now I think the baby's head is in the lower pole, breech is in the upper pole, and this is the back is on the right side. Therefore, I anticipate the baby's heart or the shoulder should be somewhere in this point. So I keep the pinard on the anterior shoulder like that, and I use my hand, left hand, to stabilize the fundus, and then I bring my head down. Listen to the fetal heart. You can take it out to dampen the sound, prevent the dampening of the sound, and if I want to count, I can count with the watch in my hand, and then I take it out and finish my examination. Now, if you take this lady who is having a symphysis fundal height more than the period of gestation, and she is diabetic, so one thing that we need to rule out is macrosomia. So estimated fetal weight, even though it is not accurate, is important in this patient. Therefore, if you look at this lady's tummy, I think the baby's estimated fetal weight is somewhere around 3.5 to 4 kilograms. So to finish it off, we thank the patient who is kindly agreed to do this demonstration.
Let's revise our knowledge on bony pelvis. The bony pelvis is consist of two hip bones and sacrum. The two hip bones will articulate anteriorly with each other at the pubic symphysis, which is a secondary cartilaginous joint. The hip bone will articulate with the sacrum posteriorly and form the sacroiliac joint, which is a synovial joint. When we are looking at the bony pelvis, and especially the hip bone, we will find this hip bone made out of three separate bones. This is ilium, This is pubis, and this is the ischium. All three bones will come and lie and attach with each other at the center of the acetabulum. At the center of the acetabulum is displayed here. When we are looking at the hip bone, it is very important to remember some landmarks. Here in the ilium, anteriorly, we will find the anterior superior iliac spine, where the inguinal ligament will start. Anterior superior iliac spine will continue with the iliac crest. Coming down from the anterior superior iliac spine, we will have the anterior inferior iliac spine. From the anterior inferior iliac spine, we will have the superior ramus of the pubis. Here, we will have the pubic tubercle, where the inguinal ligament will attach. Then we will find the body of the pubis. The body of the pubis will continue down as the inferior ramus of the pubis, which will articulate with the ramus of the ischium and form the ischiopubic ramus. Here at the bottom, we will find the ischial tuberosity, which is very important bony prominence for the obstetric examination as well as for the sitting. When we are moving to the posterior aspect of the hip bone, here we will find the lesser sciatic notch. Then we will move upward where we will find the ischial spine. Again, the ischial spine is very important for the obstetric examination as well as for the procedures such as pudendal block. Here we will find our greater sciatic notch, and here we will find the posterior-inferior iliac spine, and here we will find the posterior-superior iliac spine, which will also again continue as the iliac crest. For the teaching and the academic purposes, we divide the pelvis into true and the false pelvis. This imaginary plane will pass anteriorly, starting from the pubic symphysis, then in the pubic crest along with the pubic tubercle, and then the pectinate line and the arcuate line of the ilium, passing through the sacroiliac joint and in front of the ala of the sacrum and the sacral promontory. So this plane will divide the bony pelvis for the academic purpose into a false and the true pelvis. This anatomical division, which is above this imaginary plane, is what we call as the false pelvis, which has a very little significance in the obstetric point of view, which will support the growing or the enlarging uterus. It is more important to know about the true pelvis, which is below this imaginary plane. Let's have a look at the true pelvis. For the demonstration purposes, I have removed the left-sided hip bone. The true pelvis is below this imaginary plane, which I described before. Here we will have the pelvic inlet. Then we will have the pelvic cavity, and here we will have the pelvic outlet. When we orientate the hip bone in the anatomical position, where the anterior superior iliac spine and the pubic tubercle are at the same vertical plane, we will have an inclination of this pelvic inlet of 55 degrees to a horizontal plane. But when there is a sacralization where the fifth lumbar vertebra will fuse with the sacrum, this inclination angle will increase. This will lead to a bigger inclination angle, more than 55 degrees. When you have a increased angle of this inclination, there will be a delay in engagement of the head of the fetus. Also, when there is a lumbarization of this L5 and S1, where the first sacral vertebra, which will fuse with the L5, vertebra and separate from the rest, this inclination angle will reduce. This will lead to an easy engagement of the head of the fetus. Let's go through the pelvic measurements. As I described before, we have the pelvic inlet, the mid cavity, and the pelvic outlet. At the pelvic inlet, we have the transverse diameter greater than the anterior posterior diameter. So, this will facilitate the head of the fetus, if it is a cephalic presentation, to engage in the transverse manner. In the mid cavity, when you are looking at the pelvis, this anterior posterior, the transverse diameters are almost equal. But when you are looking at the pelvic outlet, we have the anterior posterior diameter, which is greater than the transverse diameter. So during the vaginal delivery, there is a transposition of the head from the transverse position to the anterior posterior direction at the mid cavity. Let's briefly go through the normal and its variations of the pelvis. The gynecoid pelvis, which is the quite normal and the most common variety in the Caucasian females. Then we will have the android pelvis, which is more or less equal to a male pelvis. Then we will have the anthropoid pelvis, which resembling that of an anthropoid ape with a much lengthened anterior posterior diameter and a shortened transverse diameter. Last, we will have the platypoid pelvis. This is shortened in the anterior posterior diameter and increased in the transverse diameter. Let's have a look at the pelvic outlet. The pelvic outlet, we divide it into anatomical pelvic outlet and the obstetric pelvic outlet. This obstetric pelvic outlet is an imaginary plane starting at the pubic symphysis. On either side, we have the ischial spines, and posteriorly, we have the fifth sacral vertebra. This narrow pelvic plane is very important for the internal rotation of the fetal head, which will enter through the pelvis in the transverse manner if it is a cephalic presentation, and then at the pelvic outlet with this internal rotation will have anterior posterior direction. And this imaginary plane is important for the pudendal block. When we consider the pelvic outlet, the anatomical pelvic outlet, when we have a look at this, as you all can see, it is a diamond-shaped pelvic outlet anatomically. The diamond-shaped pelvic outlet is made by this pubic arch anteriorly and posteriorly by the tip of the coccyx, and then on either side is by the ischiopubic rami, these two, and then we have the sacrotuberous ligament. So the pubic arch, the ischiopubic rami, here we have the sacrotuberous ligament and coming with the tip of the coccyx, which will form the anatomical pelvic outlet. Thank you.